authorities were not prominent in the early stages of the pandemic. And it wasn't until June 2020 that regional teams, which involved local government officials, were set up by the government to help with the management of outbreaks. So I'm just going to say a few words about the methods. Our research addressed the health impacts of COVID-19, focusing on testing, tracing and isolating strategies. It was part of the EU-funded Project Periscope. The research involved 10 experts in central and local government. They were from a central government agency and 6 diverse local authorities in England, covering rural, urban areas, cities and towns, and different regions of England who didn't focus on the countries outside England. The experts included 4 directors of public health, 2 assistant directors of public health, 1 former senior local government official, 1 local authority consultant, and 2 local authority officers. So we've got diverse views from our participants. So starting with testing and the early challenges. There were various challenges at different points in the pandemic, but very early on, the biggest challenge was the lack of scale testing availability. And it wasn't possible to test people, find out someone had COVID unless they were sick enough to go to hospital. And one major issue arose with the discharge of patients from hospitals to care homes. And at the outset, government guidance did not require negative tests prior to discharge. However, one local authority in our sample decided to implement testing prior to discharge in March 2020. And this was a challenging decision, according to our interviewee, taken in advance of the national policy. It was facilitated by a really strong partnership with our acute hospital trust. This was one positive thing we did. We're really pleased we did it. And so this just highlights some of the challenges that were faced between what national guidance was saying and then what the public health imperative was. At the outset, the major issue nationally was the lack of an appropriate testing infrastructure to respond to a pandemic. The government increased testing capacity and invested in testing technology, including PCR tests and lateral flow antigen testing devices known as LFDs, or I'll talk probably about LFTs, lateral flow tests. That's the term that's commonly used. Very early on, Public Health England recognised that there was not the workforce availability to carry out swabbing for everyone in the country who needed it. Public Health England therefore carried out work looking at how well people could self-swab compared with assistance swabs. And this was the basis of the decision to move to self-swabbing tests, which was relatively different from the rest of Europe. So this focus on self-testing was very different. There were gargle tests in some countries, but this idea that the general public eventually should be able to do testing themselves was rather different. The organisation of PCR testing, which was the only test available early on, and that was assisted testing, as you will know, it was a key issue early on in the pandemic. Public Health England considered drive-through sites to be the easiest to set up quickly and likely to hit the highest numbers. But regional sites required transport to access them. And interviewees noted that accessibility was a challenge in areas where many people didn't drive. Public Health England subsequently defined a walk-in model and local testing sites were developed. And this is a quote from one of the interviewees who said, "We wanted to make sure that the sites that we had were as accessible as possible, particularly because of low car ownership, and that the sites were accessible to people from Black and minority ethnic groups and on low incomes. The key thing for us was to try and make sure our local test sites were within a 20-minute walk because there wasn't always public transport." In one area, with a large, mainly Pakistani Muslim community, the council was very keen to get a site in that area. There had been a big regional testing centre, but the council knew from previous experience that those kinds of health initiatives didn't often reach people in these communities who needed to be accessed so that they could actually benefit from the testing. Once testing was underway, there was a challenging period at the outset, as Director of Public Health couldn't access data regarding cases. So they were left in the dark, which was highly problematic. And there was also a lack of data about the characteristics of those who had died of COVID. In one local authority, the Director of Public Health heard about excess deaths from the local registrar of births and deaths, but there was no information on ethnicity. The Director of Public Health started talking to local clinicians, and subsequently the local authority put together data on ethnicity before there was mainstream collection of data. And as the interview said, and as we all know, eventually data showed that you had a much higher risk of being very ill and dying if you were from certain ethnic groups. So this was an early discovery, if you like, at a local level. And then that was fed back to the central level. But it was an early discovery because of acute observations. And I want to talk briefly about digital exclusion and hard to reach groups. So one of the challenges with the testing infrastructure was registering results, registering tests and results online for people who were digitally excluded. So as one of the interviewees said, if you weren't digitally competent to do things like scan a QR code and add your details multiple times, that was quite difficult. The whole infrastructure was set up for a result by mobile or email. And another interviewee commented, central government is very good assuming everybody's got access to a smartphone. Amongst some communities in some deprived areas, people don't have access. Quite a few elderly people weren't confident, and lots of people around here don't have the internet or smartphones. So they were unable to register test results. The testing sites provided the capability to elderly people who wanted to test, and of course, others as well. And I should flag up also that the Central Agency, Public Health England, did set up a non-digital process whereby people could call for their results. But as you will recall, the main focus was on recording and providing material online. Now, turning to hard to reach groups, local authorities use different approaches to encourage hard to reach groups to be tested. In some local areas, mobile testing vans were used to reach communities who would not come to a testing site. And councils employed workers who could speak relevant languages to facilitate testing. And as one interviewee said, a lot of our team we got from an agency, and it just happened that we got people who could speak Arabic, Chinese, and Eastern European languages. It meant we could go into certain communities, which would otherwise not have been the case. And in one area, people on 0-hours contracts, and there were a lot of them in this area, were reluctant to test because they couldn't afford to get positive tests. So they wouldn't test. Because they knew if they were found to be positive, they would be told that they should isolate, which they wouldn't be able to afford to do. In that case, the local authority set up a large community championship network, and they got volunteers working with them from different communities. And the Director of Public Health would brief them on a weekly, fortnightly basis about what was happening. One local authority, as part of surge testing for new variants, set up trusted networks and established sounding boards. And there were different sounding boards for different groups, Bangladeshi, Pakistani, Black African people with disabilities. And these trusted organisations came together with the public health team to test out ideas and get feedback. And as the interviewee commented, these sounding boards really helped us build trust. And we got 5,000 people to come forward for testing. Testing centres were in mosques, the Hindu temple, and other trusted places. In specific circumstances, local decision-making came to the fore. For example, where there were outbreaks which required a swift response. So in one local authority, there was an outbreak in a prison. The local authority decided to carry out testing from a public health point of view. However, they had to fund the testing. We shouldn't have had to pay. We commissioned an external provider to come and do the testing to prevent onward transmission within the prison. We made the right public health decision, but there's no clarity on the funding stream. There was no formal policy. So policy was slow to develop when these situations arose. There was also an outbreak at a university in one area. Following a proposal from the public health team, the chief executive took the decision to carry out mass testing of student halls of residence. Everyone rallied round to try and get us the resource for the mobile testing so that we could test. We found 800 positive cases. So at a local level, there was this possibility, this facility to actually carry out testing, but the big problem at this point was the lack of resource from central government. Local decision making was also of paramount importance in other circumstances. For example, when the military was brought in to assist with testing. So in early 2021, some areas were asked to carry out surge testing to identify variant concern cases. Bringing in the army had to be well managed, as one interview said. We said we don't want any uniforms worn, or it would do more harm than good. Another local authority called in the army following an outbreak in a neighbouring area where the army had been brought in, and they knew that they were running behind this other area. And the interviewee actually went to the army base, and I said, this is the initiative we need to follow. That has been used in the other area. The request was signed off by the Minister for Defence within 12 hours, and the army were in the local authority within 24 hours. So that was a speedy response. The local authority felt that it was imperative that this testing took place in a very timely manner. A major advance was with the development of lateral flow devices, lateral flow tests. Initially, they were for professional use, which was a limitation. Public Health England pushed forward building the evidence base to show that people could effectively take the sample and do it for themselves. And they were to show this approach worked. When lateral flow testing first became available, it was rolled out as an asymptomatic screening test for people with no symptoms. So it was targeted on specific groups who were still needing to leave home to work. And in one area, construction firms also asked for their workers to get tested before going to work, because they were finding that if one person had COVID, it knocked the whole team out. By the end of 2020, there was widespread accessible lateral flow testing for the general public, with a switch from a model where individuals had their tests supervised to a system where people came to collect tests and take them away, or they could order them online. Lateral flow tests played a very important role in enabling schools to reopen in January 2021. Schools were required to carry out testing prior to opening. As one local authority interview commented, that put immense pressure on the school system, really practical stuff like who was going to do it, space to do it, and therefore taking children away from lessons. Schools were getting guidance, but in this local authority, we did make the decision in December 2020 for the Christmas break that we would provide testing on behalf of schools. And that was against national policy. So here again, we've got another example of guidance proposing one way forward and the local authority deciding to go another way forward. So having considered reasons why they weren't going to pursue the government line, they went in a different direction to assist schools with the opening process. And in one area, secondary schools were fairly self-sufficient in getting tests from the Department for Education, and primary schools were the big issue because even though teachers were testing, children under 11 weren't. And the first indication in this area they were getting outbreaks in the community was through primary schools. And so when this authority reached the threshold for an outbreak, they'd send in the team with the mobile testing van, and lateral flow tests went to the schools and the kits were handed out to parents. And then once it got to that level, teachers and WhatsApp groups would explain this to the community. So you've got this really important role being played by the local community. In another area, testing in schools was reported to have gone well with testing days and showing people how to carry out the test. But the problem then arose when the results came back and head teachers were checking through their notes and asking how they should proceed given the information they now have. So lateral flow testing was very, very important in opening schools in January 21. Turning now to contact tracing, local authorities had some very limited involvement at the beginning of the outbreak. So, for example, one interview noted that they knew about one isolated case the month before the first lockdown. Now, responsibility then shifted to the central level. And one of our interviewees found this particularly frustrating, as there'd been an outbreak of measles in the area the previous autumn amongst adults with learning disabilities. And they'd been doing the tracing, so they had the expertise, they knew what was involved with the tracing. And of course, it wasn't on COVID-19 scale, but nevertheless, they had this expertise, and yet this expertise was not being used. So at the central level, contact tracing initially sat with Public Health England, and a number of interviews did comment that they felt that they could do this better locally, because they understood their populations. And subsequently, a decision was made to procure a national contact tracing service. This was centralised outside Public Health England and run as a separate system, part of NHS Test and Trace, which I can tell you more about at a later point if you're interested how that worked. And so, although NHS Test and Trace was responsible for national contact tracing, it didn't work with local authorities at all at the outset. Local authorities got some information from Public Health England and meetings with them. They'd find out about a breakout by those meetings. And it took many months of fierce lobbying to get any meaningful contact, and especially resourcing to supplement the national contact tracing efforts, even though directors of public health knew that they would be able to get better, quicker reach. Policy did shift, so it's important to note that there was some policy learning, if you like, over time. It shifted in August 2020 when the Department of Health and Social Care announced a change in focus for the Test and Trace programme. Local and national teams would work as one. So you got this change in terms of how government, central government was viewing local government. I'll try and get through this quickly because I'm aware of the time. But if the National Contact Tracing Service wasn't able to reach people, it passed information to local authorities. Now, these were the difficult cases already. Local contact tracing teams had the names of individuals who'd been contacted by NHS Test and Trace and individuals who had been recognised as contacts, but the data were really limited. And what local authorities were able to do was to cross-reference to those contacts to see whether they had tested positive, and they could use local data, so council tax databases, for example, and a whole range of other forms of data that they had available to use. In one area, a group of teaching hospitals, public health officials and data scientists from public health came together to share data. They held weekly meetings, shared updates and talked about difficulties. Many participants talked about the problems with the national contact tracing system. The central tracing system didn't really work. It's again down to the sort of communities around here. It needed that local contact tracing to be done using remote teams who didn't understand the community, ringing from a 0300 number that people won't answer. So that was the real problem, that the national teams were not able to access individuals. And as you know, 0300 numbers are UK-wide, and there's they're non-geographic, and people tend not to answer calls from those numbers. Interviews highlight the importance of local knowledge and local understanding for contact tracing. And so there was a nice example provided of a case of a man who's late 80s with COVID, who the national system had not managed to reach for 3 days. And the local authority was very concerned about this. And they managed to track him on an alternative number from his GP, and they found him with his 16-year-old granddaughter who was looking after him. The child's mother was ill in hospital with COVID. The family did not have food. So the local authority put out food and the man's medication from the doctor. And then they contacted Man's daughter in hospital and reassured her about her father and her daughter. So this person had been left for, and his late 80s had been left for 3 days. So the local authority felt that that's a real achievement, that they had actually had this success, which the National Contact Tracing Service had not had at all. When there were massive surges, the National Tracing Service wasn't able to reach people because there were too many cases. One local authority had 2,000 cases come through one day. The big fault in the national system was when it couldn't cope. Everything came to the local level, but there was no extra money, no extra resources. The local authority did some prioritisation in terms of who that they should focus on in the first place. And they did that in terms of the needs of the individuals concerned, not the order coming in, which is what the national team would do. And so they were using their local knowledge and intelligence to do the best they could in a very stressful situation. And so the view was that contact tracing definitely worked better at a local level. It was resource intensive, and of course, when you've got a big surge, an outbreak, you get to the point of contact tracing where you've got so many cases, it utility is limited in value. One interview commented that we got there pretty quickly. In a number of cases, our local authorities eventually took on all the contact tracing. And I think the main point I'd like to flag up here is that because it was carried out locally, they were able to get a whole household in one go. So they didn't have to make separate calls to any individuals tested positive. Anyone else in your household was reported to you. And they had their own number as well, and public health nurses would make the calls and would start with, well, how are you feeling? Which is not even part of the national script. And another local authority recruited staff with languages from the local community, and that was a really helpful early warning system because they could find out about outbreaks really early on. In order to engage with vulnerable communities, different approaches were used. In one local authority, community teams included multilingual speakers from communities where the authority was struggling to make inroads. Well, people were working in insecure jobs in the food industries, and which they also had concerns about. And they were being picked up by a bus 50 miles away to work in a production factory and driven home in the evening. The community teams who carried out the door knocking and contact tracing were existing staff. Others were also recruited, including Roma-speaking people. And then again, as in the other examples, the contact tracing team weren't just asking people to remain at home and not go out, who they'd been with and so on. They were asking how they were, they got enough money, and you get your food. Now, turning to isolation, I'm not going to say very much about isolation. Local authorities were sent information regarding individuals who were isolating or fielding for help for other reasons during the pandemic and needed support. And councils provided a range of practical support, including food, medication collection, dog walking. And in one local authority commented, community organisations provided food for people, dropping things off at people's doors, and the council provided nappies and things for babies. You managed to support people to get medication because you can't order paracetamol. Now, initially, there was no financial support for those who were not able to work from home, but later local authorities did get money from central government to give payments to people who had to isolate. And just before concluding, I'd like to talk briefly about communications from central government, because communication is so important, and it was so important during the pandemic. And one of the concerns was about announcements from central government. And I'm just going to read these out because I think they're quite illuminating. Often you would hear stuff on Twitter or on the news before you got the press release from the government about it. I don't think it was colleagues in the Public Health Agency, it was the politicians. It thought they were making stuff up on the hoof. And then another interviewer said, Boris Johnson would stand on a podium at 5 o'clock at night announcing something that we had to implement the next day. We didn't have enough time to be able to implement things as we want to. It would have been good if we'd had a bit more of a heads up. And then sometimes there was a mismatch between what was happening locally and the mainstream media. And so in one case, the local authority was sending out 800 messages a day to people who had been in contact with somebody with COVID. But the mainstream media message was saying that transmission isn't happening. People on the ground all said, schools are absolutely full of it. You end up thinking, what's happening here with the messaging? So there were problems with the announcements and the fact that it didn't actually ring true on the ground. In terms of communication, language and culture, the interviewees had some different comments that they made. They weren't actually asked specifically about these issues, even the really few issues that they mentioned. And so there was messaging coming from central government that was good, but a lot of it kept changing, confusing people. One of the problems was that all the guidance was in English. This meant that information could be shared in English quickly, but then it had to be translated. It caused delays. Local authorities had to set up comms in different languages and easy read because the national comms were not fit for purpose for our local communities. And that goes throughout test, trace and isolate. Another comment was slightly different. We've got a large Pakistani community, a large Indian community, quite a large Eastern European community, and then a British white community, so quite diverse, different cultures. The public health team went in with the imams to local community centres. They addressed each community and there were different requirements in each. So this need to tailor communications to particular groups is really important. And the final point I want to mention on the communication issue is that the interpretation of household culturally for many people was family, but family lived across more than one household. Because of the way they interpreted the message, they thought it was fine to get 5 households together because they were all the same family. So this lack of clarity in terms of the language used and what that language meant to different people is really important. So going forward, that these sorts of issues are issues that really should be addressed and thought about in advance, so as to avoid confusion and unnecessary onward transmission of viruses. And finally, I just want to say a word about governance, partnership and funding. And interviews commented on the positive relations between central governments and the key central agency, Public Health England, and its successor body, UK Health Security Agency. Interviewees really welcomed the introduction of a regional structure, which, as I mentioned earlier, was not there at the outset. There was no local authority involvement, but local authority officials were actually part of the regional structure. Resourcing was a key issue. I've mentioned that previously. And as one interviewee said, for local authorities to have an active role, they need to be resourced. Without adequate resourcing, they play the game of risk or muddling through. Communication was important. Communication needs to be done centrally, as a lot of people still do get information from the BBC News or the ITV News, but it also needs local government to reinforce that message. Trust was important. Central government needs to trust local government to make decisions, given the expertise at a local level. The word trust is a key one throughout everything, and you'll recall that in some of the quotes that I gave in previous, this idea of trusted feeds through the responses from the local authority officials. And finally, one interviewer commented that on community empowerment, we've got to give people the tools to do some stuff for themselves. And that was apropos of what happened prior to the final lockdown, when people decided for themselves that they were not going to go out and socialise. So in fact, people's behaviour preceded the policy changes, preceded public policy. I'm going to end there. I know we're running late, and I know there's another group that is ready to begin. So thank you very much for listening. Okay, I think if I'm So we've got any questions before we move on?
I'm Bez Blake from Newham COVID Champions. One thing that you mentioned about misunderstanding through language,
Yeah.
put some young people there,
Yeah.
and through my experiences, there were members of different families that English wasn't their first language, and the young people acted as interpreters. So I would speak to the young people,
Yeah.
and they would speak to the rest of their family.
Yeah.
But I did experience that a lot of the older ones, they thought staying in a household bubble meant the whole family
Yeah.
didn't go
Yeah.
somewhere
Yeah.
else.
Yeah,
So,
exactly.
Well done, you young people, helping out.
Thanks, Edmund. Okay. Anything else?
So the track and trace,
Yes.
it kind of, from what you're saying, do you feel it actually worked? Because it seems like it didn't work on a local level, and it kind of didn't work on a national level because it was too much information gathering, and there wasn't enough people to actually follow up the trace, so to speak.
Yeah,
So do you feel that it worked?
I think at a national level it worked to some extent, but other research suggests that it was pretty problematic, and that once it got to a local level, it was more likely to be successful. Now, whether it actually stopped people socialising is a different matter. But in terms of it actually getting to the relevant people and conveying information about what should be done and shouldn't be done, but also providing incentives, if you like, saying, well, we can help, we can support you. I think that probably was helpful. And I think that probably did work. It was certainly more effective than the national contact tracing, which was hugely problematic. I think anecdotally, I think,
And, you know,
as well.
I think on the beginning of your slides, he was talking about that no one, well, from my understanding, it was saying that no one thought about getting into those local groups in the beginning, and then almost by default. So no, my question is, the people that are making these decisions,
Yeah.
like to the National Health Opinion, whoever they are, I would have thought that England being so diverse, that would have been the first thing you would have thought of, was to get to those communities, because they're the communities that might not have internet access. They're the communities that might not watch ITV BBC. They might just hear it from a local imam or from their mosque. So I would have thought that would have been the reverse. So sometimes I wonder that the people making the decisions, they maybe should have people from all of these communities on those boards in the beginning, say, what do you think we should do to get to your community, instead of a waste of time before it kind of picks up.
No, I think that's a very, very valid point. And it did happen at a local level, but then there was a learning that took place there, and it worked in different ways in different places. Well, that's fair enough. That's not surprising. I mean, one of the things I think is quite interesting is that the material that had to be translated, it must have cost an awful lot of money to translate all this material in all these different local areas, because it took quite a long time for the English versions of the national guidance to be translated, and then it wasn't going to be fit for purpose in any case. So again, I think something along the lines that you're suggesting would have been a way to proceed, and it's something that could be taken forward in the future, I would have thought.
Oh, thank you.
And just on that point, I can sort of add a little bit of information there, which is that people at the centre, because I was one of the subcommittees that were saying we should be doing these things very, very early on, but the government did not believe in structural inequality. The ability to actually get special advisors to take that on board was impossible. Yeah, and that's why I made the point in the earlier presentation today that, you know, Bangladesh and Pakistani communities were badly hit in the second wave, and then they went hit really badly again in the third wave, even though there's clear guidance from saying from ethnic subcommittee that they should be doing something. So this is what we need the COVID inquiry to be talking about.
Yes,
So,
yeah.
but it isn't yet. I don't know if it will, but yeah, I just wanted to mention.
Can I just add something? On the point of people perhaps sitting on boards with the national government, I know in Leicester, for example, the local government actually found people from different communities. And like my mum was the person who represented the Somali community, and she was able to do an interview in Somali and explain the COVID restrictions and what you can and can't do and how to test and all that stuff. And that was then distributed amongst the different community groups, and it was sent to different group chats, stuff like that. So I feel like local government did a lot better than national government in terms of distribution. Yeah.
And of course, they know their own communities as well, local authorities, they know who they've got living and where those people are living and what their needs are going to be. And they can, and if they don't, they can set up, and they did set up different sort of forums to actually try and